This presentation will demonstrate the appropriate technique for the fixation of a transverse mandibular symphysis fracture using two 2.0 mandible plates. The method provides stable fixation by adaptation, relying on the bony buttressing of the fracture. It's technically easy, but is not as stable as lag screws or compression plating. The objectives of the exercise are to understand the importance of correct occlusion and anatomical reduction to reproduce the original shape of the mandible before fracture fixation is begun, and the correct technique for applying two 2.0 mandible plates. This is the clinical situation. Preoperative radiographs are needed. CT scans may also be used. The standard approach for fractures of the symphysial region is intraoral. The instruments needed are two bending pliers, the reduction forceps, the holding forceps with ball tip, the 1.5 millimeter drill bit with 6 millimeters stop, and the 1.5 2.0 cruciform screwdriver shaft with handle. Before open reduction and fixation in the dentate patient, the correct occlusion must be re-established. For this exercise, Ernst ligatures have been selected to hold the occlusion. The model requires two monocortical holes to be drilled at the superior border on either side of the fracture to help when placing the reduction forceps. In the clinical situation, caution should be taken not to harm the tooth roots. The mandible halves are manipulated until anatomic reduction is achieved. This fracture is to be repaired with the two-plate technique. The first four-hole 2.0 mandible plate is applied to the inferior border of the mandible. The plate is contoured with the bending pliers. The plate is positioned a few millimeters superior to the inferior border. On the bone model, the holding forceps with ball tip is used. A 1.5 millimeter drill bit with 6 millimeter stop is used to drill monocortically through the plate hole next to the fracture. A 2 millimeter screw, 6 millimeters in length, is inserted. It is not fully tightened until the final reduction and plate position are confirmed. A second screw is inserted on the other side of the fracture in the same way. Both screws are tightened. The forceps is removed and the remaining plate holes are filled. A second four-hole mandible plate is used as a tension band near the superior border. Care is taken to avoid the tooth roots. The reduction forceps is removed. It must be confirmed that the reduction is adequate and fixation is complete, and that no gapping exists on the lingual aspect that would lead to occlusal disturbance and mandibular widening. After plate osteosynthesis with two plates in isolated median and paramedian fractures, no MMF is needed. However, it is recommended that the patient stay on a soft diet for 4 weeks. The fracture is now stable, and limited function is allowed. This exercise has shown the importance of correct occlusion and anatomical reduction to reproduce the original shape of the mandible before the fracture is fixed, and the correct technique for applying the two 2.0 mandible plates. With this method, fixation is stable and technically easy, but it's not as stable as lag screws or compression plating.